Hello, Declan.
Hey, Renu.
How are you?
All good.
I love having guests in the studio.
I know you do. We're on a good run of them at the
We're
moment,
on
actually,
a
aren't
good
we?
run. Yeah, we've been having some superstars visit Melbourne and Peter Mac, and today is no exception.
Who have you got today in the seat beside you?
Oh, let me just check. Hello, Danny.
Hello.
So we've got Dr. Danny Heng from the University of Calgary, medical oncologist, huge expert in kidney cancer. Here in Melbourne.
Yeah, and great. Welcome to the studio. Welcome to Melbourne, Danny. And you're joined by a friend of the podcast, our colleague
Very
Peter
familiar face, Lewis.
Hello.
Lewis
Thanks for having
Au,
me back.
welcome back.
Thank you so much.
Yeah.
Actually, before we start, I've got some feedback for you both, actually, Renu and Declan.
Oh.
I saw a patient a couple of weeks ago, new diagnosis of kidney cancer. And even before I met him, he's doing his own research and came across this channel. And he said that it was actually really informative. So,
Wow.
yeah. So just a bit of positive feedback to say it's reaching a broad audience and clearly excellent content. So
He must have been referring to an episode that you were on, Lewis, because you do have a way with words.
There we go.
wasn't sure, but it's great stuff.
That's fantastic.
Well, we do appreciate that, and we do know that our audience is quite mixed, as we were just talking to Danny about, and a lot of patients do listen and watch this podcast.
Yeah.
So it's great to hear that feedback. And actually, on the YouTube channel, more than others, we get a lot of comments, and we always reply to every single comment, and a lot of them are from patients. So thank you very much for the feedback.
Yeah.
And to patients out there, we hope this will be a good one. So you
And
came
I think
up,
sorry, go on.
You came up with the title for this podcast today.
Did
Is this you?
Well, no, I wanted to say advanced kidney cancer for urologists, and you changed that to dummies.
Right. I know. And
So it's Declan's fault.
advanced kidney cancer for dummy, or for me. That's what you're saying, is it?
We're all dummies.
Well, there you go.
I don't think
He's
so.
very generous.
So we have two big experts on advanced kidney cancer here in the room with Lewis Au and Danny Heng, and that's what we want to do. Pick your brains on three areas.
That's right, because we want to try and simplify it a little bit. Kidney cancer is this fast-moving area, lots of advances just in the last couple of years.
Yeah.
And now even with imaging. So we really want to try and pick the three big topics in advanced kidney cancer.
Okay, so that's what we're going to do over the course of this podcast. So what the three things? First of all, this is going back to, I suppose, a lot of Danny's pioneering work on risk stratification. Maybe we'll talk a bit about that as we talk, that whole database with the International Metastatic Kidney Cancer Group. So my question was, what sort of patient is this? When you've got a newly diagnosed patient or a recurrent patient with you. So we want to talk a bit about risk stratification. How do you put a patient into a particular box to say this is your type of cancer and these are the options? So number one, what sort of patient? Number two, novel scans and biomarkers in kidney cancer, a bluffer's guide, because occasionally we're up against more erudite podcasts like Euromigos, our mates on Euromigos who know all about
Danny's been on Euromigos.
Of course he has. Yeah. So we want you to give us a bluffer's guide in case we're back on Euromigos and we need to talk about novel imaging and biomarkers in kidney cancer. That's the second thing. And the third thing, neoadjuvant and adjuvant stuff in kidney cancer, because this is real urology territory. So what the urologist needs to know. So there you go. And you've been at the MDT at Peter Mac this morning, Danny, with Lewis and the team, and I think you probably enjoyed that. It was good to be in there.
Yeah, you guys are hard workers, plowing through all of them. It's and just seeing all of the scans, the PSMA PETs, the CA9 PETs. It's just inspirational. It's really cool.
Yeah, that's great. It is a good group to work with in there, Lewis, isn't it?
Yeah. It was a particularly long list actually this morning, but so glad to have had your opinion on some of them actually.
The discussion was really great. And I think, what Michael Hoffman pointed out was that, we're using more and more of this CA9 scanning, which is very new even to us. And it's kind of going down that same trajectory that PSMA PET did for prostate cancer, figuring out what to do about these results, how it changes your management of patients. So it's interesting as we go forward.
Yeah, pioneers. Yeah, that's pretty cool.
Okay, so first topic, then Renu. What sort of patient is this? Risk stratification made easy. So Danny,
Risk stratification is a complex topic.
It is a complex topic, and Danny and team have tried to make it easier over the years.
Yeah.
Yeah, so metastatic renal cell carcinoma is a very heterogeneous disease. There are different histologies and there are different risk groups. Stage 4 metastatic disease is not the same for everyone. There's some really indolent cases. There are some really fast, aggressive cases. The IMDC criteria are 2 clinical criteria for lab criteria, so KPS less than 80%, diagnosis to treatment interval less than 1 year, anemia, high platelet count, high calcium count, high neutrophil count. Those are all the prognostic factors that we use. And we used it in the age of VEGF targeted therapy, and we've been able to look at it in the age of IO therapy, because we're in IO combination therapy world now. And so all of the prognoses of the patients have quadrupled since the interferon era. So we've definitely made a lot of inroads with our combination immunotherapy agents and how we do things. So when I see a patient, I think about their histology, I think about their risk stratification. Intermediate poor risk individuals can have Ipi/Nivo, for example. Here they can have other combination therapy as well, pembro, lenvatinib. Favorable risk individuals are very, very interesting because they have a very long prognosis. And so what do you do with those? And so we can talk about a bit about that later. I also think about their comorbidities. I think about, do they have their kidneys still in situ? I think about how healthy they are, whether or not they have sarcomatoid histology or not. And then that's how I decide, okay, do you need systemic therapy or not? And what systemic therapy do we give? Yeah. And so that's the basic gist of how I see a patient.
Yeah. Actually, I want to, put into context, perhaps for our listeners not as familiar with, this IMDC score that obviously, Danny, you've developed, and how actually incredibly important and useful it is in kidney cancer. I think, fundamental problem that we face in kidney cancer is exactly as you've said. I think across any solid tumors, we don't see this extreme broad clinical phenotype. Just this morning, we saw these incredibly indolent cases where there's a patient who's relapsed, almost a decade afterwards, versus there are some patients who, have disseminated widespread multi-organ metastasis right from the beginning. So, having actually a easy to use clinical metrics that can give some indication of prognostication is incredibly important, particularly for kidney cancer. And I think it's really been very, very helpful for clinical practice on a really practical level. So
thanks, Lewis. That's awesome.
Yeah, no, it's really, really important.
And I think it leads to, very tailored treatment. Yeah. And like we said at MDT this morning, it is amazing to see these patients 5-6 years down in clinic, and it's because they've had good systemic therapy.
Yeah.
And I suppose the IMDC, and we'll put the links in the show notes, has been around for many years, with more than a decade now.
Yeah, it's 12. Yeah, 2009 was our prognostic factors publication, and so and then Checkmate 214 made it official for the intermediate poor risk patients gaining benefit from Ipi/Nivo. So yeah, it's been quite a ride, and we're very lucky. We keep trying to refine it every 6 months. So every 6 months, we put it through the ringer, through SAS, to see, can we add something to the prognostic factors? We add all of these things, but it just turns out to be 1% different or 2% different. And so we haven't changed it, but one day we will. Do we add KIM1? Do we add transcriptomics? Do we add imaging? Do we add CA9? Do we add AI? So one of those things will change it, and we keep working on it.
Well, I think, though, that's, Renu, one of the beauties of it, and we'll come to that in the next question about novel scans and biomarkers. But one of the nice things about IMDC is it's kind of stayed with rather basic parameters that are out there when you're assessing a patient initially. It's straightforward kind of blood tests and stuff like that. So would you say, Lewis, there's almost no excuse to say, well, a new patient or newly referred to you, first thing to do is to put all that together so you can see where is this patient sitting on the IMDC risk table. Is that what's in your workflow, or you teach
Absolutely. I think it is absolutely standard that everyone should be able to derive the IMDC criteria from the get-go to, it does have implications for treatment selection. It does, in the current treatment era. But actually, Danny, I've been dying to ask you this question and thinking about this as well. I'm so glad that you're saying that you're constantly trying to refine the way we categorize patients. I know in recent years there's been some talk about perhaps a new category, the very favorable risk. I think it's been presented a couple of years ago. Do you want to talk us through about that? Does it really select for an additional category of patients?
Yeah, even within each risk category, there's heterogeneity. So the intermediate risk group is almost 50%. So can we identify those people a little bit better? In the favorable risk patients, it's about 25%. And there's a very favorable category. So people that have very good prognostic, very good KPS, 90, 100%. People whose diagnosis treatment interval is more than 3 years, not just 1 year. And people without lung, liver, or bone metastases. So these are the very favorable risk group. And we found that they are very responsive to VEGF inhibition. And the people that didn't get the people that didn't get a VEGF inhibitor, so if they just got Ipi/Nivo, for example, their overall survival is inferior. Oh, right. And so this is hypothesis generating, obviously. It's not practice changing, but it does make me pause, for someone who's very, very favorable, do they need some sort of VEGF inhibitor in there, like, Axi/Pembro or Cabo/Nivo or something like that, or just even a VEGF inhibitor on its own. And so those are questions that remain to be looked at with the very favorable risk cohort.
Yeah, I mean, that's got direct implications for the Australian treatment landscape, because currently for the favorable risk category patients, the reimbursed option is VEGF-TKI. And, having heard what you've just said, it does actually put us at more ease in recommending that treatment. And, it's a, non-uncommon question or patient for us to bring to MDM. How do we treat these favorable risk patients? Because, I must admit, and I get these from trainees as well, some aspects of IMDC is a little bit subjective, particularly with, when to start the treatment within 1 year. So, sometimes we think to ourselves, as clinicians, do we sway patients one way or another based on a gestalt? Are we doing someone a favor? So, the additional category of this favorable risk is actually really important.
Yeah, and I think, things may be different in different jurisdictions. And so for favorable risk in Canada, I try to use combination therapy, but with a VEGF inhibitor. Right. And so, because the CR rates are quite high, and we do have these long-term CRs, and we might not want to use very heavy combinations that have a lot of side effects. We might want something that's more tolerable because they're going to be on it for a very long time. And so it'll be interesting to be able to study those differences. Do we need that VEGF? Do we need the IO? How do we combine them in the favorable risk? And the cool thing about the IMDC is we have patients from all of these camps, and then we can compare them and see, what should we be doing and affecting things from there.
And then where do you take the risk stratification tool? I mean, do you have an app? Can you just enter things into a risk calculator and get some treatment options for these patients?
Yeah. So we have a website, imdconline.com, and if you type in IMDC on Google, it'll pop up. There's also MedCalc calculators and other calculators as well in different languages like Russian and Chinese. And when I first saw them, I was like, oh, that's so cool. Yeah. But so you can input things in there. I think it's very clinician focused because I think we need to explain what those prognostic categories mean, because there's a lot of nuance. Just because you're intermediate poor risk doesn't mean you must have this treatment. There are nuances like what is the side effect profile? How healthy are you? Do you need an urgent response today? So should we be using a VEGF plus IO therapy instead of Ipi? So do we want a more durable long-term response? Can we afford that? Can we afford to wait for that? Can we afford hyperprogression? Those are some questions that we think about in our heads it's not encapsulated in the IMDC criteria.
Yeah. There we go.
So dummy summary for me then on this first section is, this is easy to do and there are tools out there. We'll put the links in the notes. So everyone should be thinking, and I'm sure patients do as well, because they want to search, which category am I in?
But also it's very useful for even clinicians like us urologists. Yeah. If we go to this, we know exactly how to work up these patients as they're being sent to a medical oncologist, what test to order, what to look for.
Yeah. Oh yeah, are we missing something in this? Exactly.
Like
How we check the calcium.
Calcium.
Exactly.
Yeah.
Calcium. Exactly.
That's right.
Yeah. But also, it's not just because in risk stratification, sometimes you're thinking, because of course, if I have poor prognosis things, I want to make sure I'm getting intensified treatment and getting the best. But the other aspect you've just spoken about is the more favorable ones. Yeah. So I presume the two reasons to do that, Lewis, are number one, to avoid maybe overtreating patients or exposing them to treatments with plenty of side effects or cost as well. And also, is it true to say if you keep the IO combination, you can have it for the future, rather than if you do a VEGF or a TKI based initial approach for the favorable ones, you can still be using it. You haven't blown that weapon early on.
Yeah, I mean, there's reimbursement restrictions as to, how we can use IO and what sequence. In general, I don't know if you agree, Danny, we really should be thinking about doublet treatments for patients with intermediate and poor risk. But the decision there is, in Australia at least, it's whether it's Ipi-Nivo versus lenvatinib pembrolizumab. For patients who have just VEGF-TKI in the first line, then they have access to nivolumab as a single agent in the second line. So sequencing is a consideration, but by and large, I think doublet therapy is gold standard for patients, not in that favorable risk.
I agree. Yeah, and we want to use the best therapies up front,
Yes.
right?
I like that. Yeah.
Because not everyone gets to second line therapy.
Exactly,
Only
yeah.
58% of people get to second line therapy. Not everyone gets to third line therapy. Only about 57% of people that get second line therapy get third line therapy. So we want to use the best drugs first.
Definitely.
Okay, if this dummy is feeling better informed,
Don't save your good treatment. Good.
it's going to get more complicated as it goes on. I mean, you picked all this.
There's biomarkers in the next sentence. That's a bit scary.
Yeah, every time I listen to other oncology podcasts and they say, what we need is a biomarker in this. One of my, to be cynical about it, interpretations of that is we've been saying that for years and years about everything in oncology, and so few actually make it into frontline to help pick out the best treatment for the best patient. But nonetheless, that's not to put pour cold water on it.
But the novel scans is interesting.
Yeah.
I'm very excited about that.
And at the MDT this morning, you were chairing it, Renu, but Michael Hoffman and Shankar Siva and co were there, and we very much wanted to talk about novel scans because we have interest in molecular imaging and renal cell carcinoma. So we want to talk about novel scans, and Lewis, I know, has work going on this, and also biomarkers. And it flows back into the first one. Do you see, like KIM1, the kidney injury molecule, etc.? Will these come into your risk stratification? So Dummies stuff on novel scans and biomarkers, if you don't mind.
Yeah, I mean, Lewis, I might start with you because there's been a lot of focus in recent times on the zircon scan, and that's the girentuximab. But we've sort of taken it one step further at Peter Mac with the CA9 imaging. Maybe you could tell the audience a little bit about the differances and what are some of the advantages.
Yeah, no. It's been really exciting in the field of sort of functional imaging for kidney cancer because, before, the advent of these new scans, what we've got is CT scan. And there's limited information to be gained in terms of functional status. I mean, we have been using FDG PETs for kidney cancer for some time, but it's not a great scan. I think it does pick up, the particularly aggressive type of kidney cancers, but by and large, it's not the sort of scan of choice. And, the advent of CA9 scan is particularly exciting because what CA9 refers to is a protein that is upregulated in kidney cancer in particular. It's very different to normal tissue, but of course, there's some native CA9 expression in stomach and other predictable areas, but by and large, it's a really good,
very specific,
much like PSMA in prostate cancer, right? So currently, I think there are two CA9 scans that's sort of still in the research setting. It's not widely implemented yet, but then there's the girentuximab zircon scan, which is an antibody-based tracer. And then we are trialing a new type of CA9 scan at Peter Mac, which is a small molecule CA9 tracer as well. And, for us, with gaining experience with the new small molecule CA9 tracer, we're seeing excellent results. I mean, the resolution is just exquisite. We saw some in our MDM this morning. The SUV max for some of these cases is 100, 200, and that gives really, really good information about small metastasis that may be occurring, and it's a very convenient scan as well. We get pictures on the same day within hours.
Within hours, exactly. I think that's one of the biggest differences, again, with the practicality of doing these scans. But you're right, the tumor to background contrast is just striking.
Yeah.
But I mean, it's very early days yet, and we really are obligated now to show what the impact of this imaging is going to be, and a lot of that is going to depend on biopsy confirmation of tumors, of areas that light up on this small molecule CA9 scan.
Yeah. Well, I might just throw it out there to discuss here. Actually, I think the CA9 scan, the output of this will be that we're picking perhaps CT occult, low volume disease that we're not traditionally seeing. And I think what we're going to find ourselves in is that we suddenly find ourselves, all these patients with small volume, more widespread metastatic disease. And, my gut feeling is that we really should be using the sites and the distribution of disease as the information that's going to guide therapy. I think, in kidney cancer, whether you've got liver metastasis and bone metastasis is very different to if you've got lung versus nodal metastasis. I don't know, where do you feel the CA9 scan is going to make impact, and how should we use that information? What's your prediction?
Yeah, I completely agree with everything you've said. So, and another thing I would also add is maybe a thought about velocity of growth and serial images to see, yes, we have a 2 millimeter thing here, but is it still 2 millimeters 3 months from now? Because that's a very different story than something that's growing a lot faster. We are still in the research experimental stage, and I think it's very exciting though. And I think, pairing things with biopsies, double checking to see what it's like, going through what PSMA PET had to do for validation would be really important for us to be very confident about what we see on those scans. What I don't want to see is that we end up overtreating everyone with doublet therapy or triplet therapy when it comes, because that could be very costly, but it could also lead to a lot of side effects that aren't needed. And so there's that balance of, sometimes when you know too much, you might change things inadvertently. And so that's something that we need to balance and need to do clinical trials about.
Just this morning we saw a couple of muscle and subcutaneous metastasis, and whereas we used to think, these kidney cancer mets in these sites are really rare, right? But I think we're going to find that they're
and we
less
also
common.
see heterogeneity in these lesions. Some lesions that are very hot, SUV max of 100, like you said, and then other lesions that are different, and we don't know what that difference is, until we get tissue diagnosis from all of this and can put it into context.
Yeah. So not quite ready to drive practice yet, right? Yeah. We still have a lot of thinking and being thoughtful about how to choose therapies and how to interpret these scans.
But the other exciting thing, Danny, is the potential for theranostics. When you've got something like that, just like we did with PSMA PET and now lutetium PSMA treatment, where do you think the future might take us?
Theraноstics are everywhere, right? Yeah. And especially in GU, all of us are using PSMA guided therapies, lutetium, and there are new compounds and new theranostics as well. And so I think it's an exciting world. For renal cell carcinoma, we have to do the trials. We have to be thoughtful about it. We can't just adopt it right away. We need to see some prospective clinical trials to look at their efficacy. But I'm really excited about it. And this is a great place to do it here at Peter Mac.
Yeah, just a shout out on that topic, actually. Michael Hoffman is going to be giving an educational session on that at ASCO this year, actually. So, that would be very exciting. And I think he was saying he might show some early data about the theranostic effects.
Well, we saw a little sneak peek this morning, Declan. It was very impressive. But, in the era of IO drugs, which do carry a lot of toxicity, targeted treatments like this do seem tempting.
Yeah, and as Danny keeps saying, they need to be studied and done prospectively. But luckily, we've all got friends with our nuclear medicine physicians over the past decade, thanks to prostate cancer. So it's just another great partnership. You're working with a different craft group, and they're experts on theranostics. They're not experts on renal cell carcinoma, but these kind of MDT meetings, and it has worked well in our group, Lewis, where we've done a lot of that with prostate for more than 10 years now. So,
and it's always nice to have a different mechanism of action, right?
Exactly.
Not another VEGF inhibitor or another PD-1 inhibitor. So it's nice to do that.
So I want the Bluffers Guide on biomarkers.
The Bluffers Guide on biomarkers. So that's novel imaging. Bluffers Guide on biomarkers. I'm only going to ask you one question about it, Danny, because from my other listening to other podcasts is that this KIM1. So can you please give us a bluff? See?
Yeah, I'm impressed already.
It's the one that just seems to be right. There's a lot of utility potentially. So for bluffers like me out there who, I don't do any kidney cancer personally anymore, but I try to keep on top of it. Tell us a bit about KIM1 and what the bluffers need to know about that, or any other biomarkers, without overwhelming us on this
Sounds good.
Dummies podcast.
Yeah, I could do this for 40 minutes. I know you don't want that, but I do have a talk for 40 minutes on it. Kidney injury molecule 1 is a blood test. So it's not $4,000. It's not it's literally less than $100. You could do it the same day. You could transport it. You can mail it. So it's very accessible. And whenever there's kidney cancer, there's secretion and shedding of KIM1. You could also see it in They've done it for renal failure and stuff like that as well. And so Vincent Zhu and his group has done a lot of studies looking at the Checkmate 214 data, showing that if you have a higher KIM1, you have a poorer prognosis. If you have a higher KIM1 level, you have more IMDC criteria. If you get treated and your KIM1 level goes down, you are better. If your KIM1 level goes up, you're worse, and your overall survival is worse. I think what we need to do is refine it a little bit, because the people where the KIM1 level goes up, there's still 13% responders. So it's not like there are no responders in that group. So as you can see, it's not a black and white phenomenon. It's kind of gray everywhere. It gives you a hint that maybe you should push this way. Maybe there's a hint that maybe you should switch therapies, but we're not quite there yet. We're still in the experimental phase. I'd like to see it in the adjuvant setting. Like after you take out a kidney, did your KIM1 disappear? And if it did, that's great. Maybe you don't need adjuvant
like a
therapy.
PSA.
Right, yeah, exactly. But I guess the question is, what level of KIM1 is good, safe? Just like what level of PSA is safe? But if it does go up, does that mean we need adjuvant?
And what about cancer cell death? So if you treat a patient and their disease responds and there is cancer cell death, does that lead to an increase in KIM1 even transiently?
Yeah, I mean, that's a really good question, actually. I think fundamentally, we've gotten this signal about, KIM1 levels being measured and some signal about correlation with response. But actually, I think now's the time to step back and understand exactly where KIM1 is coming from and how that changes dynamically with treatment. I hope I'm recalling this correctly, actually. I think from ASCO GU just last year, Laurence was showing some data that the change in KIM1 level actually goes in different directions depending on which agent is used. So I think, my personal hypothesis is that because the KIM1 is actually a surface molecule, it's sitting on the kidney cancer cells, depending on the mechanism of cell death from the therapies, the dynamic change could be different. With immunotherapy, responses lead to KIM1 reduction, but with targeted therapy, responses lead to KIM1 increase.
Okay.
I actually think that it's because, with immunogenic cell death, immune cells are mopping up the cancer cells. KIM1 is mopped away as a reflection response, whereas with targeted therapy, there's necrosis and cell death, and KIM1 is just released into the bloodstream. So I think, now that we've gotten the signal, my prediction really is that we need to spend time to understand fundamentally, where KIM1 is coming from, how that tracks dynamically with different regimens, what the right levels are. And I think we need to do that work before taking it further. And I think that's really to safeguard patients before implementing it as a biomarker as well. But, hugely exciting. We've been screaming for biomarkers in kidney cancer. Tissue-based biomarker has just not yielded for many reasons. And, the fact that we've got a signal from a blood-based test is hugely, hugely exciting.
Amazing.
That is. And do you use it in clinical practice? Notwithstanding what you just said about studying it carefully, but can you order one? Or?
Well, not yet. It's still very much in the research setting, actually. And I think implementing that into prospective clinical trials, I think is the key. I think that's how we're going to generate high-quality data, and that's the way to move it into clinical practice in due course.
And it would be really easy to build it in, right? Because it's just a blood test.
Yeah.
And so if you have a protocol, add it, and then you have more prospective data. And so I think it would be really easy to study. There's so many things unanswered. So in the Checkmate 214 data, they measured it at 3 weeks. So there was a change in KIM1 already at 3 weeks. But it only worked with Ipi-Nivo. It didn't work with sunitinib. It was kind of a dog's breakfast with sunitinib. And so, can it be used with VEGF inhibitors? Should it be at 3 weeks? Should it be at 3 months? Should it, there's so many things that we need to answer.
I want to see it combined with functional imaging. I think that would be very exciting, reduction in, I think that would give us a lot of information.
There we go. We've got a clinical trial now.
There you go.
It
does seem like there's a lot of potential to embed that into some of the neoadjuvant trials, right?
Yeah.
Because then you've got tissue as well to compare with functional imaging.
Yes.
And before we finish on the biomarkers, Danny, on that, because for example, things like PD-1 and PD-L1, when all the IO stuff is coming out, and this is precision oncology, like PD-1 and PD-L1 have disappointed really, haven't they, would you say, or it wasn't going to be immediately this patient is going to respond really well. That's why we're going to use this expensive drug. What's your take on it? How do you use PD-1, PD-L1 in practice?
So I don't.
You don't.
So I don't use PD-L1 testing. I feel like all of these things give us hints in clinical trials. So if you're PD-L1 positive, yes, you'll enrich for a more responsive population, but the PD-L1 negative population still responds, just not as much. And so you don't want to discount a whole population that still responds based on that. But maybe if we added all of those together synergistically, like PD-L1, KIM1, transcriptomics, whatever else, and put it into a score. Maybe one day we'll be able to use PD-L1, but I don't routinely use PD-L1. I think it's just for experimental research purposes and for knowing what's happening.
Little utility as a single biomarker in kidney cancer.
Yeah.
Are there any other biomarkers on the horizon for kidney cancer?
Yeah, I think, the other aspect that we haven't talked about is tissue-based biomarkers. And, like I've alluded to before, a lot of research for many years has gone on, but nothing's translated, to clinical practice yet. There's been really exciting fundamental work by Brian Renu and his group, defining the different subtypes based on tumor transcriptome. But the main problem with kidney cancer is intratumor heterogeneity, meaning that if you biopsy one area of a tumor, it's going to give a different signal to the other area. And, that problem really scales up with stage 4 disease. Actually, I've been involved in some work, trying to estimate how much of the tumor are we actually sampling when we, hand over a test in a clinical setting. The answer to that is that we're actually just sampling 0.0005 percent of the tumor. That's 5 cells in a million on average in stage 4 disease. So when you think about kidney cancer, when particularly with primary tumors, you're going up to 13 centimeter masses. We're dealing with trillions of cells. So the fact is, it's a really high bar to be able to get a biomarker from tissue off one sample. Yeah. I think there's still hope. I think the goal is to be able to find a signal that isn't subject to intratumor heterogeneity. There is work being done in that space, but I think it's important to recognize why it's been so challenging in kidney cancer.
Wow.
Great summary. I love it. Okay, we're moving on.
Okay.
Final topic for you urologists who are still listening. So neoadjuvant and adjuvant, we've talked about a lot on the podcast over the last 5 years, Renu. You do a lot of kidney cancer surgery and you're involved in some of these trials with Lewis. So adjuvant pembro is kind of, after Keynote 564 has dropped right in there as a standard of care for these higher risk patients for adjuvant. But we want a dummies guide to, where are we in 2025 with neoadjuvant and adjuvant? Which patients and, would you agree is
how do you
standard of care?
them?
How do you select them? Or what trials are you excited about ongoing in neoadjuvant and adjuvant? So who wants to kick off? Both are nodding.
Well, should we start in the adjuvant space first?
Sure.
Okay.
Yeah.
Danny, do you want to?
Sure. So adjuvant kidney cancer, finally we have something, right?
Yeah.
There have been so many negative clinical trials with VEGF inhibitors, with chemotherapy, all sorts of things, and we've never had a new standard of care. And so now there's adjuvant pembrolizumab with the Keynote 564 data. So there are specific inclusion criteria, right? T2 grade 4, all the way to M1 NED, clear cell renal cell carcinoma, so not other variant histologies. And there was a DFS and OS difference. So we use it now. And I must admit, I love our urologists. They text me. They're like, Danny, I've got this patient. And I'm like, no, it's papillary. Let's not do it. Or they text me and, what about this patient? I'm like, yeah, let's. So because of that constant communication, which I really, really appreciate. I love our urologists back home. They really refine who we see. So instead of having to see 400 people, we see a more refined group. And I would say we give about 80% of them adjuvant pembrolizumab. There are some people that we don't want to overtreat. And there are some people that we don't want to undertreat. And I think we're still feeling out that space. So what I mean by that is, someone with a T3 grade 2 no necrosis tumor, if you use the S-sign calculator, or if you use the adjuvant assure calculator online, you just Google adjuvant assure calculator online, it'll probably spit out a recurrence risk of about 20% or so. And I think that maybe that risk isn't high enough to warrant a year of immunotherapy. And on the flip side, someone who is T4 and has like the tiniest pulmonary nodules, those people I don't like giving adjuvant immunotherapy to either. I think people need a whistle clean CT scan, clean as a whistle CT scan, because if you're worried that there's any metastasis at all, in 3 months, you've already started the Pembro, you could be undertreating them. Maybe they should be getting Ipi-Nivo or Len Pembro or something like that. And so that's kind of the art to adjuvant kidney cancer now. But I would say that we're using it a lot more now. And then the next step will be what happens when they recur, if they recur, and what do we give them? Should we be using immunotherapy again? Because in Australia, there's a once in a lifetime type rule. In Canada, there's a 6-month rule. So if you recur within 6 months of getting adjuvant immunotherapy, you're not allowed to get any more immunotherapy. In EMA, there's no rule like that. So you can use it whenever you want. So we need to collect that data to see what is the sweet spot. And we need to do clinical trials to see what is the sweet spot for when we can re-challenge with immunotherapy again.
I really appreciate it, or like the way that you've put that as saying there is an art to discussing adjuvant therapy for kidney cancer, because I think it's just so nuanced in the way that we need to apply these data to patients, right? So in the Australian context, we're equally excited about the trial results. It's a well-conducted study, it's high-quality evidence, it shows a survival benefit. But currently it's not funded. And I think, in Keynote 564, the inclusion criteria, I think, is actually very broad. You've alluded to the fact that even within the inclusion criteria group, the risks for relapse can be vastly different. For someone with a large tumor with sarcomatoid differentiation, is vastly different to someone who's T3A, grade 2, no other adverse features. So I think in the discussion for adjuvant immunotherapy, we do actually need to drill down to these details to put forward a rational proposition to the patient. Based on your risks, is the benefit afforded by adjuvant pembrolizumab worth the toxicity, the costs at this very moment, and the subsequent implications for access to immunotherapy? So I think there is an absolute art to it, and I think patients do need to hear the information, but it comes down to a very nuanced discussion and careful discussion.
It's a difficult discussion to have, and at least for the time being, while it's not funded and it's so expensive, I think that adds another level of discomfort and complexity to the discussion with that patient, especially patients who are motivated to do everything but just cannot afford this treatment.
Yeah,
and that's a part of the discussion. And so for someone who's a little bit iffy, I do say that. Are you the type of person that wants everything under the sun? 1 percentage point is important to you. If so, then maybe you should do it. If you're the type of person that doesn't like hospitals, doesn't like doctors, doesn't like infusions, maybe you shouldn't do it. Those are for the 20% risk of recurrence people. And so I do have that type of conversation because it is very personalized, and it goes to that art that not everyone should or wants to get it, but you have to ask those questions.
Dummies question then for you as well on that, Danny, is because adjuvant, for people out there, patients listening as well, means that the patient's had a cancer operation, and for a cancer that looks confined, and so a very large number of them, like in Keynote 564, half the patients I think are cured effectively. So adjuvant means we're going to offer them a treatment based on the fact that maybe half them will recur in the future. So it's a different conversation, isn't it, compared to the patient's been referred to you now and he or she has some metastases. So the bar has to be higher, doesn't it, for safety and side effects and so on. So how do you sit with your patient in front of you who, this patient has a 50% chance of being cured? I suppose my take on it is it's a very nuanced conversation, but also it's reassuring, especially if the intervention is not funded. If at the moment in Australia pembrolizumab is not funded, then there is some reassurance to be had that, look, we know we have great things that we can offer you if you do recur in the future. So tell us a bit about the conversation to the patient in the adjuvant setting.
Yeah, so my conversation is, hey, there's an immunotherapy that we can use to cure you more potentially. It's not a massive difference. The difference could be small. And I think the difference is different depending on how high risk you are. So there's actually very nice Kaplan-Meier curves of by stage. the higher stage you are, the more benefit you derive from the adjuvant pembrolizumab. So there's effect modification. I do talk about, there's also 3 other clinical trials that were negative looking at adjuvant immunotherapy. And why were they negative? Was it because it was only 6 months of immunotherapy? Was it because it was an inferior drug? Was it because the side effects were too difficult? And maybe that's why they're negative. So I do introduce that to the conversation as well. And then I do say, here is your risk of relapse according to the S-sign or the adjuvant Assure calculator. So in my EPIC, you guys have EPIC. So one of my EPIC smart phrases is, the S-sign recurrence risk is this, the adjuvant Assure recurrence risk is this. We talked about adjuvant pembrolizumab. These are the pros and cons. And in the end, we decided this. I do talk about side effects because it's adjuvant, it's not metastatic. If you have metastatic disease, you're willing to take on all sorts of side effects. If you're already potentially cured, you might not want those side effects. And if someone gets, lifelong arthritis, they're going to be really upset with you if you didn't talk to them about it. So I do go into a more detailed conversation about side effects. I do say that, you could get a skin rash, you could get colitis, you could get LFT abnormalities. But I do say anything that could become inflamed could become inflamed. So that's actually my EPIC smart phrase. And things like you could get diabetes requiring insulin, or you could get...
Which could be lifelong.
Lifelong. Yeah. And so those are differences in the adjuvant population that maybe we might not discuss as much in the metastatic population.
I might have to steal your smart phrase from you.
Yes,
that's very
useful.
For me, I think... I don't know if it's the right or wrong thing to do, but I actually talk about, adjuvant treatment as almost like an insurance policy for patients. It's, the sort of language and concept that it's much more easier to grasp for patients. And I think once they are in that space, then they can think about, the value proposition for them, the tolerance for risk, in a way, insurance policies are done. And I think when you talk about the benefit being adjusted to their risk, what we're really talking about is relative risk reduction. And that, in oncology, in statistics, we talk about hazard ratios, but actually, who actually understands or can explain hazard ratios, right? But actually, I think this is really important. The hazard ratio for benefit for the trial is 0.62. And what that actually means is that at any given point during your treatment, you're about a third, less likely to have an event. So the benefit is, about a third. And I think when we talk about someone with high risk of relapse, I personally think it's wrong just to talk about the absolute benefit from the trial. I think what's actually more meaningful is to talk about the relative risk reduction. I think when you put it that way, the value proposition for the treatment suddenly changes. And I think that, to me, is a much more useful discussion for patients with particularly high risk.
I think it's more personalized as well, because they're hearing it. So you're talking about me, it's a 30% reduction for me of my risk of metastases or death. So I totally get it. But it's a nuanced conversation. Bits I liked in that.
And it really does matter how you put it, because Danny was saying this morning, we discussed that patient with PT3A disease. Danny was saying, actually his risk of recurrence is 20%. By using this drug, you will reduce it to 17%. And, be mindful that this is going to be $65,000 and all the toxicities associated. So that does also help to put it into perspective for, say, a low-risk patient.
Yeah, for sure. But and it's also important, all patients are different, right? So in the breast cancer world, for example, a 3% difference is huge, and it will be funded and used. And so, in urology, for whatever reason, we have very high bars for overall survival benefit, and so it really depends on the type of person that you're seeing.
Yeah.
Has it really been 45 minutes?
Oh, almost.
Wow.
We're nearly there. So there,
we've done a lot of fun.
Yes, we could talk about this forever.
Bits I enjoyed, by the way, from the last 10 minutes or so was Danny saying, he starts the conversation in adjuvant saying you might be more cured. Yeah,
more cured. I like that. Yeah.
That was
everyone wants to be more cured. Yeah.
These patients I was saying were cured. Well, you might be a bit more cured.
Oh, just a little more.
You can pick that one up as well, Lewis.
Like more pregnant.
Yeah. And the other thing, Danny, before you finish, was I loved your story about your urologist texting you, because one of our themes in adjuvant, of course, is lots of urologists are seeing a patient a few weeks after their nephrectomy and they've got PT3A and may not be fully tuned into the idea that there is a conversation this patient can now have, because this is still relatively new era of adjuvant options. So it's great to hear your urologists are texting you. Do you want to give them a shout out? Who has your number in Calgary?
I love you guys. Jeff Gatto, Eric Hyman, Bimal Bindi. You guys are fantastic. Marty Duffy. There's so many more. Okay.
It's great. That's great. Make sure they have it.
I love my urologist too. Sitting right there.
Say it, Lewis.
It is the same at our centre. Yeah, they're very receptive to a text message, which does help us as well, because sometimes you're just not sure.
And things like the papillary tumours that there's not an option for, it can be easily weeded out.
And they'll answer quickly, and you're saving a patient an unnecessary wait for a consultation. So it's very, very helpful. So great. There you go.
Wow.
Done. 3 great topics for advanced kidney cancer for
I feel
dummies.
smarter now.
Yeah, that's right.
Yeah.
You're already very smart. I feel
You are
I'm
very
almost
smart.
at your level. So that's all we have time for on this episode of GUcast. Oh, gee, it's been great to have Danny Heng in the studio and Lewis Au back in the studio as well.
Absolutely.
So we're very
Thank you
grateful
so
to
much.
you. And thanks for being in Australia. You've got dinner with the team tonight, I know, as well, in town, and then off to Sydney for the CTIO meeting, a really good immuno-oncology
And
meeting.
Danny, make sure you wear your GUcast beanie in
my
the
toque,
snow of
yes.
Calgary.
I
Your
will.
toque, yes.
Toque,
yes.
they call it in
Two.
Canada.
Yes, yeah.
I'll send you the photo.
There we go.
That's the picture. Fantastic. And we will put links in the show notes to the IMDC calculator and the other one, the Assure adjuvant calculator, etc. So any of those things we mentioned, we'll stick a link in the notes. And so thank you very much for joining us. If you did like this, of course, as usual, subscribe, rate, review us. And if there are particular topics you want us to talk to, get in touch.
See you soon.